at this session. Welcome, sir. Over to you.
Yeah. Welcome, students, and I would like to congratulate first the students who have taken up this task of presenting today. And we have two interesting topics for the day today. So the first one will be a debate which has always been an area of debate and which continues to be surgery versus concurrent chemoradiotherapy in stage 3A or stage 3B NSCLC. So, and which would be followed by management of pleural effusion. So for the first talk, we have Dr. Raj Patel, who will be speaking in favor of surgery, and Dr. Sandeep, who will be speaking in favor of Ctrt or against surgery, more or less. So not wasting much time, and we would take all questions at the end of the completion of the talk, so that it would be easy, both the talks I mean, and then after that we will take it forward how it goes. Okay. So yeah, Dr. Raj, over to you.
A very good morning to everyone. So today I will be speaking on surgery for stage 3 non-small cell lung cancer. So stage 3 is a unique disease in lung cancer, just for the sake that it has got a very heterogeneous group. The T and N varies right from T1 to T4, when there is invasion of the local structures, and from N1 to N2 to even N3, which makes it unresectable. And there has been some recent change in classifications in 2018, which has caused some stage shifting. There is also a lack of quality evidence regarding either modality of treatment, and there is an ever-evolving armamentarium which can be used for management of these patients. Day in, day out, there are multiple new strategies which are being suggested, and there is a lack of clear-cut evidence into this. So we can see here that from 7th to 8th edition, the 5 to 7 centimeter and more than 7 centimeter margin has been changed, wherein T3 and T4 diseases are allotted now to the respective centimeter groups. But the important thing is there is no change in the nodal category in this. We can see here that from N0 and N1, which includes 3A and 3B, and 3C, which includes N2 and N3, what we are worried about in N2 and N3 is the systemic control, whereas in N0 and N1, we are worried about the loco-regional control. So specifically regarding the N2 disease, which makes the prognosis very poor, it can be either an incidental N2, which we found intraoperatively. It can be an ignored N2, wherein a suspicious node may be present on imaging, and it has been missed for the histological confirmation, and there may be an obvious N2 which we had detected pre-operatively with a mediastinal staging. So EGCC had tried to divide this station groups into single station N1, multi-station N1, skip metastasis to N2, N2 with N1, and multiple N2, wherein different prognosis is there with worsening prognosis with each level. But what is important is it is only for the sake of prognosis. It should not be used to guide the treatment decisions that has been stated in the EGCC 8th edition. Regarding what we are dealing with lung cancer in our country is 37% and 30% in male and female respectively are the loco-regional disease that falls into this stage 2 and stage 3 category. What are the options we are having? So an incidental N2 wherein a surgery has been a first modality, we have adjuvant options, and the evolving options are the neoadjuvant followed by surgery followed by some kind of adjuvant therapy. Such patients with N3 disease are to be evaluated extensively for their pulmonary as well as cardiac fitness. A proper mediastinal staging is also to be done, wherein for specifically N3, for specifically stage 3 disease, I would like to highlight that during the EBUS, EUS or mediastinoscopy, a suspicious contralateral node should be evaluated with a priority if suspicious, and also that the amount of tissue that we get in the biopsy should be adequate to run the biomarkers, as well as the histological confirmation should be from us.
Dr. Raj,
sir,
to interrupt you, can you just stop sharing the screen and share the screen again?
Sure, sir. Is it okay, sir?
Yeah, please continue.
So the histological confirmation should also be from the point where it would provide adequate tissue, as well as it would confirm the highest stage in these patients. So what does the guideline say regarding stage 3? Surgery should only be done when there is a complete possibility of an R0 resection, wherein a contralateral N3 nodes are not involved, and the mortality for a 90-day period should be less than 5%. But the another important thing here, which we can see in the second recommendation, is the exclusion of surgery should not be done by any non-surgical physician. A surgeon should be an active part of multidisciplinary board, and whether to operate or not should be taken by a surgeon who is involved in thoracic surgeries. What does NCCN says? T1 to T3 and N1 disease can be operated upfront for surgery, whereas an N2 positive, there is an option wherein induction therapy followed by surgery can be practiced. For a 3B disease, wherein T4 and N2, still the NCCN stays category 1 evidence as concurrent chemoradiotherapy, but when in a contralateral mediastinal node is negative and the ipsilateral mediastinal nodes also are found to be negative on mediastinal staging, surgery can be practiced upfront. Looking at a closer look at evidence, there are trials which include different modality wherein chemoradiation was first practiced, induction chemotherapy, and followed by that we have a combined modality of induction chemotherapy followed by neoadjuvant chemoradiation. And in the adjuvant, we have chemotherapy targeted agents and chemoradiotherapy. There is some real world data also regarding the management of stage 3 patients. Coming to the first intergroup trial, wherein T1 to T3 and N2 patients were selected and cisplatin and etoposide was given preoperative along with 45-gray radiotherapy, and patients were randomized into 2 groups. It was powered to see a 10% absolute benefit, assuming 25% survival, 2-year survival with the standard treatment which was at that time, but the trial had some drawbacks wherein it was low accuracy, there was a high surgical mortality associated, and it has to be stopped prematurely. The mediastinoscopy here was used for staging at surgeon's discretion. It was not a compulsory thing. We can see here that in this, among the 2 group, including more than 200 patients, around 81% were registered into thoracotomy, wherein complete resection was done in just 71% of the patients. And the consolidation chemotherapy, which was allowed after the surgery, was started in 60 patients and completed by 55% patients only. Whereas in the other arm, wherein the concurrent chemotherapy was used, almost 75% has completed the therapy. The surgery details are that 54 patients underwent pneumonectomy out of 155 resections, and there were no complex dissections involved in this study. You can see here at a median follow-up of 22 months, the 2-year survival is almost the same, 22 months versus 24 months. But what we can see here is at the end of 5 years, we have almost double number of patients who are alive in surgery as compared to the chemoradiotherapy arm. Also regarding the progression, we can see at the 36 months, there are 33% more patients who are free from progression with the use of surgery as the initial, with the use of surgery into the treatment. An unplanned analysis was also done in this, wherein lobectomy and pneumonectomy was separately considered. And we can see here in the initial first year of follow-up during the pneumonectomy group, we see a dip in almost 40% of the patients, which indicates the mortality which was associated with pneumonectomy in this group. And also lobectomy, we can see that there is a wide separation of curves when we consider the overall survival in these patients. However, the study was not randomized to detect this difference. It was an interim non-planned analysis, and it is just an hypothesis generating statement. So what we derived from this study was there was an improved OS with lobectomy, not with pneumonectomy as compared to the chemo-RT arm. The surgical superiority, however, was not revealed because the entire completion treatment disparity was there between the 2 groups, and there was high surgical morbidity which is associated with the treatment. Another important finding here was 29 patients had complete pathological response at the T as well as N status, out of which 13 were subjected to pneumonectomy. That is approximately 45 patients. So we need here a better marker which would detect a pathological response. And we can also see that in those patients when there is a complete pathological response with chemo-RT, the survival is much better as compared to residual disease. Also, as expected, the local recurrences within the surgery arm were more in the distant places, and in the chemo-RT arm were almost 45% were in the primary disease. The another trial which was also not well conducted but was taken into consideration was in 2007 EORTC trial. Here patients were given induction chemotherapy and then were randomized to either resection or continue the chemotherapy, and the good thing which we realized here was the overall response rate which was generated was 61% in these patients. However, there are major drawbacks in this study where 47% of the patient underwent pneumonectomy in the surgical arm. Only 50% of the patient had a complete surgery, that is an R0 resection. Rest of the 50% had an incomplete surgery, and that was clearly reflected in the overall survival, wherein the 2-year survival in patients was 41% and 35%, and the 5-year was 14 and 15%, which was way below the study which we just saw back. So the inclusion in this study were those patients who were deemed to be unresectable at the start of the trial. There was only 50% complete surgery rates, and there was 13% disparity between the two arms in the allocation of treatment. The only prognostic factor here was that non-squamous histology was associated with poor prognosis, and post-operative RT was associated with some improved outcomes, which might be due to the poor surgical treatment. The recent trial and the newer evidence which we see in this is induction chemotherapy followed by neoadjuvant concurrent chemoradiotherapy, and this was a German trial wherein there was a strict patient evaluation in the form of mediastinoscopy. Selected 3B patients were defined as N3 disease with contralateral mediastinal nodes, and proven T4 diseases were also very nicely evaluated. PET was used in staging, brain imaging was also done, and there was dose escalated RT which was also used in this study. However, considering the strict accrual criteria, there was slow and very less number of patients which had accrued, and it was terminated after a period of 9 years due to an inability to accrue more patients. It was an underpowered study to derive any significant conclusions for that, and the pneumonectomy rates were very high, though the mortality was very low in these patients. Only 246 patients were randomized, and 81% R0 resection rate was there, reflecting a 5-year overall survival, and progression-free survival was not different between two groups. It was 44% and 40%. The 5-year survival, as compared to previously what we saw as 14 and 16%, was increased to about 34% in this group. So it was concluded from here, though an underpowered study, that it is an option which we can practice. This is the summary of all the studies which I just mentioned, and we can see that with the newer evidence in 2016, we had got a 5-year survival of approximately 37%. Regarding those patients in whom we had got an incidental N2 node positive, there is an option for adjuvant treatment wherein LACE meta-analysis has already proved that it has 5.4% survival benefit at 5 years, and almost 30% in this analysis patients were belonging to stage 3. Also, the Iiia trial wherein in EGFR mutated Nsclc osimertinib has got a very nice response. Almost 33% were 3A disease, and N2 disease includes almost 30%, and lobectomy and the surgical therapy has also been pretty much standard in this trial. And we had seen in the recent ESCO update also that there is 63% decrease in the risk of death, specifically for stage 3 disease with adjuvant osimertinib. Regarding the adjuvant RT, it is recommended in positive surgical margin. There is no clear-cut evidence behind that, and also it can be used in some patients wherein we do not have any targetable EGFR mutation, as in a multi-station nodal positive, subcarinal positive, extracapsular extension involved, and higher node resected, which is the highest node which is resected is involved, and when an inadequate nodal resection has been done. The 2 phase 3 trials for post-operative chemoradiotherapy, the lung RT and the port-C trial, has failed to show any advantage of post-operative RT. Regarding what real-world data is there in management of stage 3 patient, this was a nice retrospective study for. So whatever data we had seen till now is from the US and the European countries. This real-world data is from non-US and non-European countries, wherein 3,000 patients were evaluated from these countries, and we can see that 53% of them were adenocarcinoma. The predominant T stage was T3, and almost 56% were N2 stage. Surprising to see here that in N3 disease, only 21% of the patients had surgery included in their treatment in any form, with either adjuvant treatment, neoadjuvant treatment, or whatever targeted treatment. The combined survival data from stage 3 and stage 4 is about 20. The median survival of around 26 months as in stage 3A and 44 months in stage 3B. The analysis showed that the progression as well as overall survival, wherein the surgical modality was offered as the initial treatment, was much better as compared to other modalities of treatment. Regarding what newer things we are having for treatment of lung cancer, immunotherapy in the neoadjuvant setting is coming with a big results, and the immunotherapy has justified its role in high antigen loads and tumor mutational burden in the preoperative setting. Also, the abscopal effect with RT in the surrounding region that we get with immunotherapy is also significant, and newer markers for response assessment in the form of major pathological response has also been introduced. So initially with the start of immunotherapy, there may be a increase in size of node, which we call an immunotherapy flare reaction, which may not be the true progression. There are evolving approaches where immunotherapy is incorporated into neoadjuvant, adjuvant, or perioperative settings. Adjuvant immunotherapy has already been proven benefit in the NADIM study and has been a grade 1 recommendation now, but there are 5 phase 3 trials for neoadjuvant immunotherapy followed by surgery which are going on. We have mature data for 2 of those trials, the CheckMate and the Keynote. Regarding the CheckMate trial, wherein 3 weekly nivolumab was given, we had seen that it has nicely benefited the patient with stage 3. But what is the impact of this neoadjuvant immunotherapy on surgery? So for specifically stage 3A patients, almost 83% of the patients in nivolumab arm ended up with surgery as compared to 72 in the conventional chemotherapy. Regarding the morbidity which is associated with surgery, the duration is also not significantly different between the 2 arms, and also minimally invasive approach can also be practiced, which was almost equally used in both the arms we can see in this trial. The conversion rates, however, was almost 11% in nivolumab arm and 20% in the chemotherapy arm. Regarding the complications which the patients suffered, we can see that the majority of the complications were belonging to stage 3 patients, wherein surrounding organ injury in the form of esophageal perforation, aortic rupture, or a intraoperative hemorrhage was also there. Regarding the perioperative pembrolizumab, it included stage 2, stage 3, and stage 3B patients also, wherein 3 weekly pembrolizumab 200 milligram was given for 4 cycles, followed by surgery and followed by adjuvant pembrolizumab. It has got a 37% decrease in the mortality rate at 3 years, which we can see here, and it should be coming as a new evidence into practicing neoadjuvant chemotherapy. And with pembrolizumab, what is its impact on the surgical procedures? We can see here that both the groups had equal lobectomies, equal pneumonectomies. The R0 resection rates were almost comparable. The hospital stay was also comparable as 8 and 7 days. Regarding the adverse event which are associated with surgery, we can see here that both the groups had almost similar incidence of grade 3 and 5 adverse events. But what is need to be appreciated here that neoadjuvant immunotherapy with pembrolizumab led to discontinuation from all study group in around 6% of the patient as compared to 2% in the placebo group. The post-operative complications were pretty much similar in both the groups, and this is the summary of what we have regarding the neoadjuvant treatment arm, wherein they are not powered to detect the overall survival, but the surrogate markers in the form of major pathological response and PCR has been used. Regarding minimally invasive surgery into management of stage 3 patients, this was a meta-analysis in the end of May the last month, wherein 8,000 patients were evaluated. The majority of the studies which were included here were retrospective or just an observational study or a prospective study, but there were only 2 RCTs. The majority of the patients, around 5,700, came from a retrospective study by Herb et al. And we had seen that in that minimally invasive surgery with either VATS or robotic associated with less blood loss, shorter hospital stay, higher R0 resection rates. And to some surprise, it has also led to more overall survival in those patients. The conversion rate across all the studies were almost 8 to 10%. Regarding what uniportal approach we can use in these patients, with the advent of uniportal approach in 2010, in 2012, this is the only paper which we had got regarding the uniportal surgery, wherein when Diego Gonzalez evaluated group A and group B patients, wherein advanced cases were more than 5 centimeter T3, T4 tumors, and 29 patients in this group of 43 were post-chemo or post-chemo RT.
Raj,
see
sorry
here-
to interrupt. Last 1 minute.
Yes, sir. The surgical time was much higher in the advanced cases. More number of nodes were in the advanced cases. But what we can see here is the ICU stay, hospital stay, and the post-operative complications was much more comparable in this group. The major drawback here is reproducibility of this same results. So we can say that a surgeon is like a captain, but to improve the survival and to raise a war against stage 3 disease, it is the multidisciplinary clinic that we required and efforts from all. These are my take-home messages wherein patient selection is the key. It should be a tailored, individualized approach just beyond chemotherapy. There should be a pace which need to be caught up by the evolving surgeons also in the surgical training too. There should be a minimizing of surgical morbidity with maximal benefit with alive patients, and there should be better response assessment, and it should be an affordable, specialized, and decentralized care which is having an accessible expertise. Thank you.
Thank you, Dr. Raj. I think we will wait for what Sandeep has to say something against your marvels, and then we will take the discussion forward. So please be ready for any points for rebuttal after Sandeep's talk. Yeah, Sandeep, you may please go ahead with your talk.
Yes. Good morning, everybody. My motion is Iiia surgery. I am Dr. Sandeep, family resident. We have multiple guidelines and we have multiple consensus statements about the surgery and the chemo radiation arm. And why stage 3 is important? Stage 3 is important because it is the second most common presentation of the metastatic disease, and is a major burden of the lung cancer, and it has this poor survival rate. When coming to the PubMed search, there are about 16,426 results in the stage 3 Nsclc. Always there is a debate which therapy is good, whether the surgery is good or Ctrt is good. Surgeons say the surgery is the standard of care, and medical oncologist and radiation oncologist say Ctrt is the standard of care. Why stage 3 is important? Because the stage 3 is heterogeneity and diversity is the major issue, and it has different flavors in the stage 3, which is N2 versus non-N2, T3, T4, N0, N1, and it has an incidental N2 disease and N3 disease, and a single station versus multi-station, and a single zone versus multi-zone disease. It includes a wide variety of diseases, which is from T1 to T4, N0 to N3, which my colleague was already has told. Coming to the survival rate, which is up to the 2010 analysis, the 3A has a 5-year survival rate of about 41%, and 3B is about 24%, and 3C is about 12%. And the options with the resectable non-small cell lung cancer: surgery followed by chemo-RT, chemo followed by surgery followed by RT, chemo-RT followed by surgery, and concurrent chemo-RT, and sequential chemo-RT or RT alone. Which one to follow? It's the biggest question. And the multidisciplinary team is the key. Various studies and various retrospective analysis, various meta-analysis showed that multidisciplinary approach is the key, and in the coordination of patient care and the diagnosis and the initiation of the treatment. And it also it must include a thoracic surgeon, a radiation oncologist, a medical oncologist, an interventional pulmonologist, a cardiologist, and a palliative care specialist, and also a social worker. And coming to the overall survival, when we are dealing with the multidisciplinary team, the overall survival increased as shown in this curve. Coming to the flowchart and approach with the stage 3 Nsclc, we have to rule out first the metastatic disease with the PET-CT and the brain imaging, and the pathological examination of the mediastinal lymph node status is the key. We have to take a proper biopsy, we have to take a proper tissue diagnosis, and we have to confirm the pathological diagnosis of the mediastinal node status, and after that we have to do a multidisciplinary approach. And the staging process will include a pulmonary function test, 2D echo, pathological evaluation with EBUS or EUS, mediastinoscopy or a mediastinotomy, or a CT guided biopsy or supraclavicular lymph node biopsy. In all the studies, in all the guidelines, one of the most important thing is pathological diagnosis should be considered in all patients before treatment initiation only and before any treatment planning. And coming to the PET-CT role, PET role as in the mediastinal lymph node status is in between 53 to 70% in different studies, as shown in this diagram. Coming to the randomized trials, the three trials were there which were comparing surgery versus Ctrt. Coming to the first EORTC 8941 trial, which has taken about 579 patients with platinum-based chemotherapy 3 cycles, which has minor response, which was taken to surgery versus radiotherapy. The median overall survival is about 16.4 in the surgical resection versus 17.5. And the median progression-free survival was about 9 months in the surgery arm versus 11.3 months in the RT arm. And the overall mortality rate was 4% in the surgery arm. And the post-operative RT is to given in about 40% in the post-surgical arm. And there are no deaths in the lobectomy arm, but there is a 7% mortality rate in the pneumonectomy arm. And this group has concluded that surgical resection did not improve any overall survival or a progression-free survival when compared to the chemoradiotherapy. In view of its low morbidity and mortality, and radiotherapy should be a preferred loco-regional treatment for these patients. And coming to subgroup analysis of the 8941 trial, which is showing the morbidity and mortality, which is operative 30-day mortality was about 4%. And 8.1% of the patients underwent reoperation due to positive margins, hemothorax, empyema, and bronchopleural fistula. And coming to the second trial, Albion group trial, intergroup trial, 0139 trial, it has 429 patients, which is taken 3A and 2 disease from T1 to T3, cisplatin etoposide concurrent chemoradiotherapy, followed by surgery, followed by chemotherapy, followed by another group randomized to radiotherapy, followed by chemotherapy. It is basically a tri-modality versus bi-modality treatment, and progression-free survival was good in the surgery arm when compared to the chemo RT arm, but the overall survival has no difference at 5 years. There is no difference versus 5 years, which is of 23.6 months versus 22.2 months. And coming to the mortality rate, there is 8% mortality rate, and the maximum deaths are after pneumonectomy. And the lobectomy curves are already discussed, were diverging after 5 years. And overall survival is subgroup analysis, which is my friend already told. There is lobectomy is better versus pneumonectomy is worse. But we can't make a decision about on this study because it is an unplanned retrospective subset. Matching criteria about age, sex, and T stage could not match the nodal recurrence, which was the most important determinant of the survival, as my friend already told. And there is no information about the rates of nodal downstaging or the response to the induction therapy. And the clinical decision making on this trial should not be taken directly that lobectomy should be the preferred approach. And coming to the third trial, which is a German trial, which is Nsclc trial. This trial has used mediastinal staging, which is one of the most important determinant in deciding the preoperative treatment, preoperative patient selection. And it compared definitive concurrent chemoradiotherapy boost in the patients with resectable 3N2 and 3B non-small cell lung cancer after induction chemotherapy with concurrent chemoradiotherapy. 3 cycles of cisplatin, then concurrent chemo RT to 45 gray, and surgery to chemo RT with about 65 to 71 gray. And it is close due to the poor accrual of 246 patients only. And the 5-year survival rate was about 44% and 40% in chemo RT group, and there is no major difference. And coming to the meta-analysis of Christopher, there are about 6 studies, 1322 patients, multiple trials, RTOG 8901, MRC, URTC, INT 09139, SPAGU trial, or compared surgery with RT and there is no significant p-value, and all the median overall survival and long-term survival are equivalent to the surgery arm. And this is a forest plot, which is the overall survival is more or less equal to the both surgery arm and the chemotherapy arm, chemoradiation arm. And they concluded that the overall there is not significant difference between surgical and definitive radiotherapy. And lateral trials using concurrent radiotherapy showed the better survival. And surgical arms tend to have an excess mortality rate before 6 months. And the all treatments associated mortality was higher in the surgical arms. And progression-free survival, there is no differences found except in the intergroup 0139 trial, which is some advantage in the surgical arm. And in all trials, pneumonectomy mortality is more than the lobectomy arm. And this is a network meta-analysis. They confirm they have all the different options they have seen, and they have networked it, and they have done a meta-analysis. They showed that concurrent chemoradiotherapy is comparable to the neoadjuvant chemoradiotherapy plus surgery. And we are talking about all these trials, all this meta-analysis, and one thing we have to make in mind that it is an imprecise clinical staging in most of the trials, and the patient heterogeneity is very, very high. And in spite of we are getting patients about 9 years and 10 years, there is very slow accrual of the patients, which was a defined accrual as not approached with all these trials. And there is a multiple in-trial variations, and these all trials were on JCC 7th edition. And coming to the benefits of the non-surgical treatment, it is a non-invasive, less morbidity and mortality, and similar outcome without involving a complex care. And we can in Indian issues, we have to take the cost. Treatment is also one of the important thing, and the minimum hospitalization. And compared to the complication and compared to Ctrt as a surgery arm, pneumonitis, esophagitis were the main concern in the Ctrt arm, which were I will tell about the RTOG 0617 trial. And the surgery, the main issues were the pneumothorax, thromboembolism, volume loss, mortality, infection, and leakage. This is a specific trial which has changed the management in chemoradiotherapy arm in stage 3 Nsclc. It is basically a durvalumab after chemoradiotherapy in unresectable non-small cell lung cancer. But most of these patients were stage 3A, which is about 52.9% of the patients were in durvalumab group, and 52.7% of the patients in the placebo group. And this has showed that median progression-free survival was about 16 months in after 18 months of 18 months, whereas 5.8 months in the placebo group. And coming to the updated recent analysis, which is of 5-year survival outcomes of durvalumab after chemoradiotherapy group, showed clearly that 5-year overall survival, which is about median overall survival of 42.9% of the patients in the durvalumab group, and 33.4% in the placebo group. And coming to the progression-free survival rate, there are about 33.1% in the durvalumab group and 19% in the placebo group. And this is continuing until the 60 months observation. And this ESMO has showed that it is consistent with the treatment benefits, and more prospective studies in the operable group need to come for the durvalumab. And ESCO says that if all the following conditions are met, then that complete resection or R0 resection and the involved lymph nodes is removed, and N3 lymph nodes deemed not to be involved, and the high quality evidence shares that it's a perioperative 90-day mortality should be less than or equal to 5% in a high volume center, then only the surgery should be indicated. And a good practice points are compulsory in our MDTT. The thoracic surgeon should be involved before any treatment decision. And coming to the RTOG 0617 trial, which compared about concurrent chemoradiotherapy, which is of 74 gray versus 60 gray, has not 5-year follow-up data confirmed that 74 gray was inferior to 60 gray. Sorry. And coming to the advances, as more and more advances are coming, comparing to the 3D Ctrt to intensity modulated radiotherapy, the main concern of pneumonitis and carditis, pericarditis was decreased, and the and there is no difference in the overall survival, progression-free survival compared to 3D Ctrt and IMRT. And which is better, whether sequential chemo RT is better or a concurrent RT is better? There's a various studies showing that concurrent RT is better. And my final take, the role of surgery limited to the single station N2 disease, which is non-bulky and a single station and a single zone. One size does not fit all. There is no level 1 clear evidence to support the routine use of surgery. Whether a surgery or a chemo radiation therapy is a equivoice until now. MDT is the key, which is involving the thoracic surgeons in the treatment decision. And stage 3 is a highly diversified group, subgrouping into N1A, N1A2, N2A1, N2A2, whether it is a single station or a multi-station, whether it is how many zones are involved, and all the zones should be pathologically staged, and invasive staging should be done. Whether the nodes are bulky versus non-bulky, which are less than 3 centimeters are called as non-bulky, and more than 3 centimeters are called as bulky. And coming, these all data which were comparing, which are of Western data, Indian data is very, very low. Only there are few consensus statements given by the few groups, starter group, and the controversies when coming to the Indian scenario, these controversies and combinations will multiply because tuberculosis is one of the main concern. The PET uptake will be more, and we have to decide whether it is single station and multi-station disease, and we have to take an economical situations into the management. We are talking about pembrolizumab, we are talking about durvalumab. Can the Indian patients can be taking those pembrolizumab and durvalumab, which is only 3.1% of the patients of Indian who are going into the immunotherapy, can be taken into the immunotherapy. And we have came a long way in terms of the surgical techniques also. Minimally invasive techniques were improved, robotic techniques were improved, and also in the radiation technology, we have IMRT, 3D RT were improved. And my stay always the restaging after neoadjuvant therapy and response assessment after neoadjuvant therapy is the key. And neomenectomy is definitely not an option when considering for surgery after neoadjuvant therapy. And R0 resection is the key when surgery is considering as a modality. Thank you.
Thank you very much, Dr. Sandeep. Dr. Raj, you have any points for rebuttal?
So just for the rebuttal, I would say, sir, that the durvalumab study, which was mentioned, wherein unresectable stage 3 patients were involved, we can see that with post Ctrt durvalumab also, we can see that 5-year survival was reaching up to 43%. Now we already have a mature data from Edura study, wherein with a very selected subset of EGFR mutant patients only, the 5-year survival with surgery and adjuvant osimertinib has reached up to 85%. So we need to stratify our patients into whom we can operate, whom we cannot operate, who are going to tolerate our therapy, who are not going to tolerate our therapy. And with a take on pneumonectomy also, it is such that we need to practice pneumonectomies also if we are doing in a setup wherein such patients are given a good post-operative care. It is not that it is not justified, but always a cure to patient is always justified. But we need an alive patient. Thank you.
Sure. Thank you. So in the interest of time, first of all, let me take this opportunity to congratulate Dr. Raj and Dr. Sandeep for actually making a wonderful presentation. I don't have any extra slide to show because all evidences have been covered. Okay, so just a few points. I would just like to highlight on a few points in a 5 minutes short presentation on management of, what exactly N2. We know why the problem is, that has been covered very well. Okay, so this is something that which is very, very important on how I classify N2 as, because all N2s are not the same and both speakers have agreed on to it. It can be incidentally diagnosed. So we have enough evidence to say that if you have an incidentally diagnosed, the outcomes are better. The recent MEDIAS trial, which looked at EBUS, and negative followed by mediastinoscopy, followed by surgery versus this thing, did not have any difference in those who were mediastinal. Resectable versus non-resectable, or bulky versus non-bulky. Any node more than 3 centimeters is considered as bulky. But remember that these are all in the pre-immunotherapy era because the response rates to chemotherapy alone was so low. So we do not know what exactly would happen in the chemoimmunotherapy era, and whether it is single station, multi-station, or multi-zone. These are important points, and this is what actually AJCC recommends, that we should start capturing data in such a way, because as of now we do not know, and we are treating a broad spectrum of N2 diseases, putting them into one basket and say that we should not be treating N2 disease. As rightly said, surgeon wants to do surgery, the chemotherapy or the radiation oncologist want to treat these patients with concurrent chemoradiotherapy. As I said, incidentally diagnosed, there is no problem, but these are some of the high risk, if you have a station 7, multi-station N2, extracapsular, or if you have, these are some area where, post-operative radiotherapy may help in these group of patients. There is no doubt in non-resectable diseases. Obviously, if you have a non-resectable disease, you're not going to resect it. So you have to plan for concurrent chemoradiotherapy in these group of patients, okay? But whether it would really help or not, or any salvage surgery can be done at a later date and time post concurrent chemoradiotherapy in a non-resectable disease, and there is no debate regarding this. We are only talking about resectable. And one important point which Dr. Sandeep had actually, the durvalumab actually has made the difference in those patients with unresectable disease, and that is where the entire debate has actually retaken back, has restarted telling that we would treat these patients with concurrent chemoradiotherapy followed by durvalumab. And even in real world, in India it might not be feasible, but then the real world data also shows that durvalumab has demonstrated durable benefit. So surgical management, there is no level 1 evidence. All the trials have been discussed by both the speakers, but preferred in single station, less than 3, lobectomy rather than pneumonectomy, but with a good response to induction therapy. Coming to pneumonectomy, as Dr. Raj mentioned, pneumonectomy cannot be thrown out of the basket just because a patient requires a pneumonia. But mind you, pneumonectomy in an N2 patient has potential disadvantages, and Ctrt followed by durvalumab may offer better benefit than surgery followed by chemotherapy. So we have different, these are the different options that we can do when we're looking at resectable N2 disease. So we have a ZAO meta-analysis, which was very well covered by Dr. Sandeep. But among all those, actually NACT followed by surgery has the best outcomes in terms of, if you are treating a resectable N2 disease, followed by the other options. So Kathy Albane has already been discussed. I will not get into this. The meta-analysis also is not very favorable towards all this thing. So it still holds a debate. It needs a good randomized control trial to end this debate at some point of time. Okay, so whether you want to give induction chemo or chemoradiotherapy doesn't matter, but induction chemo is preferred worldwide, and with immunotherapy and response rates going very high, pathological response rates going high, it's even better. Okay, so we'll not get into this. So this is one interesting study on, what are the consensus actually. So if you have a bulky disease, the consensus for concurrent chemoradiotherapy is all done. But again, if you have a non-bulky disease, the house is divided. Okay, most of them are no preference or for surgery. Even in a multi-station, it is, is either surgery or no preference. So these are multiple British societies across the world, around 11 societies across which have actually given consensus. So as of today, either in a single station or in a multi-station, there is no consensus, and it is debatable. So as everybody rightly mentioned, 60% no preference, 70% for, if it is bulky, there is no, but multi-station, we do not have a consensus as of now. Okay. And like if you have a patient who is multi-zone, most of them, 80% of them in bulky disease go for radiotherapy, and only 2 guidelines still promote you should try neoadjuvant therapy followed by a surgery at some point of time. So to conclude, incidentally diagnosed adjuvant chemotherapy, adjuvant radiotherapy in high risk, no consensus. Resectable single station, some form of neoadjuvant followed by surgery could be considered. And resectable multi-station, you could try bimodality or surgery modality, but preferred option as of today is still concurrent chemoradiotherapy. And unresectable, there is no doubt, and durvalumab will hold good. But the most important, as both the speakers rightly mentioned, patient preference should be the most important factor, and when both options are available, and they have to be discussed in a multidisciplinary tumor board. Okay, so this is what the conclusion, and we'll be happy to take questions at the end. Meanwhile, we'll finish the presentation from the other speaker. Yeah. So, coming so the next talk would be by Dr. Abhijit Tere on management of pleural effusion. So, Abhijit, try to keep it 15 minutes so that we will be able to take more questions at the end of the talk.
Should I start, sir?
Yes, please, Abhijit.
Yeah, thank you very much, Dr. Prashant sir, and the NBA giving me this opportunity on the talk of management of the pleural effusion. As we know that the pleural effusion is the abnormal collection of the fluid in the pleural space and the most common manifestation of the pleural disease, and etiology ranges from the cardiopulmonary to the inflammatory to the malignant disease. And whereas the malignant pleural effusion is basically abnormal collection of exudative fluid in the pleural space, which is characterized by the presence of malignant cells in the pleural space or on the pleural membrane. The anatomical aspect of the pleural space, as you know that there is a parietal pleura which line the chest wall and the visceral pleura which line the lung parenchymal, and the space between is the pleural space which is lined by the single layer of the mesothelial cell which secrete the pleural fluid which act as a lubricant and it prevent the lung from the collapsing. As you can see that the rate of the production of the pleural space is constant throughout the day, and majority of the pleural fluid get absorbed by the capillaries, pulmonary capillaries, and some into the lymphatics. And the balance force of the production for the pleural fluid is basically depend upon the hydrostatic pressure on the parietal space and the visceral space. And second most important factor is oncotic pressure. As in the figure 2, you can see that the hydrostatic pressure on the parietal space is slightly more as compared to the visceral space, which play important role in the production of the pleural fluid. And the net pressure in the pleural space is minus 5 mm of Hg, which play important role in the maintaining the lung elasticity and prevent it from the collapsing. The transitive effusion basically has a systemic factor, whereas the exudative effusion has a local factor, which is most commonly seen in the malignancy in the form of the increased pleural membrane permeability and obstruction to the lymphatic flow. Different causes of pleural effusion: the infectious disease, heart disease, malignant disease, idiopathogenic, and other. These are the transitive causes and exudative causes of the pleural effusion. I'm not going to the detail as a limited time frame. The causes of malignant pleural effusion: the primary will be the malignant mesothelioma, secondary mostly by the lung, breast, and lymphatic and other malignancy. As in the tabular form, you can see that the lung and breast is majorly consist of the underlying malignancy, and unknown primary also consists of 4.2%. Coming to the mechanism of pleural mets, as MPE has a visceral but not always necessary to have the parietal pleural involvement. It is basically developed when the tumor embolize to the peripheral lung and invade the visceral pleura and followed by the parietal pleura. In sometimes direct invasion from the adjacent tumor in the lung, breast, and chest cavity wall can also be seen, whereas the hematogenous and lymphatic spread also be present. The combination of the increased fluid extravasation from the hyperpermeable vessel due to the VEGF production by the tumor cell and impaired lymphatic flow, that is the main pathophysiology behind the development of the MPE. The causes of paramalignant pleural effusion basically a local effect, the systemic effect of the tumor, and the complication associated with the radiotherapy and the chemotherapy drug use. Coming to the clinical feature, majority of patients are asymptomatic, whereas the 20% of patients may be presented with dyspnea, cough, dull aching chest pain, and some constitutional symptoms associated with the underlying malignancy. The patient is generally clinically ill looking, associated with the weight loss, pallor, peripheral lymph node, and the respiratory rate should be higher respiratory rate with use of excessive muscles of respiration. In case of massive pleural effusion, the asymmetrical chest expansion and even the bulging of intercostal space can also be noticed. Coming to the investigation modality, the patient who are presented with the symptomatic malignant pleural effusion, their chest X-ray shows 80% of moderate to large pleural effusion, 10% showed the mild, and 10% showed the massive pleural effusion. There are two X-ray requested for the to diagnose with the diagnose with the pleural effusion on the chest X-ray, PA view, and lateral view. The lateral decubitus chest X-ray for the small volume pleural fluid, and the massive pleural effusion can be diagnosed on the PA view, as you can see in the chest X-ray on the right side. The ultrasonography is basically easily available, portable, and cheap. The pleural thickening more than 1 centimeter, diaphragmatic nodularity and thickening more than 7 millimeter, and the pleural nodality irregular features highly suggestive of malignant pleural effusion. Coming to the CT scan, it is a gold standard And the feature suggestive of loculation, parietal pleural thickening more than 1 centimeter, circumferential nodular pleural thickening, and involvement of lymph node can be a diagnostic of the malignant pleural effusion. It should be done in all the cases, and it can be used for the biopsy purpose. As the CT imaging shows that on the left side massive pleural effusion with the nodularity, and the middle circumferential pleural thickening. On the right side, you can see the massive pleural effusion with the circumferential pleural thickening and nodularity. The PET CT scan is basically useful for the early detection, has a sensitivity around 81% and specificity around 74%. It has a high degree of accuracy in distinguishing the benign from the malignant effusion, whereas the hypermetabolism, mostly it is seen either in the pleural effusion or the pleural space. The MRI has a potential diagnostic tool in the pleural malignancy, but it is as better for the chest wall and diaphragmatic invasion, but its clinical value yet to determine. These are the diagnostic accuracy of the different modality used for the diagnosis of the malignant pleural effusion. As you can see on the left side, there are a few very limited data we compare with the sensitivity and the specificity of these three modality. Coming to the invasive diagnostic modality, the pleural fluid analysis, basically a sample are obtained for the thoracocentesis. Preferably USG guided is always a preferred, and the minimum 50 ml is needed for the analysis, and 100 to 200 is needed for the cell block and molecular testing. The common tests which are done on the pleural fluid, basically total and differential cell count, chemical analysis, microbiological study, and the cytological analysis. These are the differential diagnosis and the feature of pleural fluid suggestive of malignant pleural effusion, the cell count, lymphocyte, erythrocyte, and the chemical analysis of LDH, protein, glucose, and pH and amylase. As in the malignant pleural fluid effusion, the light criteria has a little diagnosis value, but the malignant pleural effusion show the character of the low glucose count, less than 60 mg DL, low pH less than 7.2, and the high pleural fluid amylase. Coming to the cytology can identify malignancy in most of the 2/3 patient of the patient present with the pleural effusion. It is dependent on the tumor type and the number of specimen. And the most patient with the adenocarcinoma has positive cytology, whereas the positive rate of cytology is 25% in case of Hodgkin disease. The cytology specimen should be increase the chances of detecting malignant cell if we did a separate cytological fluid analysis. It can be repeated if the negative at least 3 times. Coming to the importance of tumor marker in pleural fluid, basically a tumor marker is utility in the high level of tumor marker with a negative cytology may indicate the confirmation test either in the form of biopsy. The different tumor marker which are the high sensitivity like CEA in case of lung and digestive adenocarcinoma, which has the sensitivity of 59, 71 respectively. CA125 in ovarian adenocarcinoma has a sensitivity of 67%. Mesothelium and the elevated cytokeratin 19 fragment seen in the mesothelioma. Coming to the pleural biopsy, what are the indication of the pleural biopsy? Is indicated when the cytology negative, but the clinical features are highly suspicious of the malignant pleural effusion. And this is the contraindication to perform the pleural biopsy. The modality used for the pleural biopsy basically a percutaneous needle biopsy. Either it can be done from UHE or CT guided, but preferably a CT guided percutaneous needle biopsy is preferred over the UHE guided. A thoracoscopy in the form of medical and the video assisted can be performed. The needle used for the pleural biopsy is known as Abraham needle. As you know that during our MBBS period also, the CT scan guided percutaneous biopsy has a sensitivity of the 80% and the specificity of the 100%. Thoracoscopy is basically an investigation of choice when the cytology and CT guided percutaneous biopsy are inconclusive and the suspicion of malignancy persists. It has a sensitivity around the 95% and it has a sensitivity similar for the odd type of tumor. It can be done either from the medical thoracoscopy or video assisted thoracoscopic surgery. Coming to the treatment modality of malignant pleural effusion, as you know that the treatment is palliative. The length of survival is basically depend upon the stage and the type of the underlying malignancy. The median survival varies between 3 to 12 months, whereas the lung cancer has the worst prognosis, gynecological malignancy has a better survival, and the survival in breast cancer is 15 months. Principle of treatment should be the addressment of the effusion in the form of evacuation and the prevention from the recurrence and address to the underlying primary tumor. Whereas the treatment option basically depend upon the symptoms of the patient, performance status, primary tumor, and degree of lung re-expansion following the initial pleural fluid evacuation. These are all the treatment modality which are available for the symptomatic malignant pleural effusion. We'll be discussing separately individually. Observation. Basically, according to ATS and according to British Thoracic Surgery Association guideline, the asymptomatic treatment is basically asymptomatic patient should be observed, and the target should be given to be treatment of underlying primary malignancy. Whereas in the symptomatic patient, the therapeutic pleural aspiration should be performed when the patient has a very terminal ill and the life expectancy is less than 1 month. The volume drain should be guided by the patient's symptoms and limited to 1.5 liter on the single occasion to prevent the lung re-expansion edema. Coming to the second modality, chest tube drainage with the chemical pleurodesis. Basically, a preferred option for the patient with the symptomatic malignant pleural effusion with a good performance course and life expectancy more than 1 month. The pleurodesis is nothing but the artificial obliteration of the pleural space, either using the chemical sclerosing agent or the physically by the pleural aberration, which subsequently stimulate the inflammatory reaction between the two pleura and lead to the obliteration of the space and subsequently prevent the recurrence. As you know that during our all MBBS and UG days, the chest tube insertion, the patient has to be educated regarding surgery and all the equipment should be arranged before proceeding into the procedure. These are the diagrammatic representation of the how to insert the ICD and the space triangle of safety, the position of the patient, and the detailed procedure regarding the chest tube insertion. The chest tube, as we know that the chest tube has to be connected to the underwater drainage area. The confirmation has to be done by the chest X-ray with the free-flowing fluid, with the air column movement, and the improving the symptoms of the patient. The draining of the fluid should be. These are the diagrammatic representation of the how to insert the ICD and the space triangle of safety, the position of the patient, and the detailed procedure regarding the chest tube insertion. The chest tube, as we know that the chest tube has to be connected to the underwater drainage area. The confirmation has to be done by the chest X-ray with the free-flowing fluid, with the air column movement, and the improving the symptoms of the patient. The draining of the fluid should be limited to 1.5 liter, as we discussed earlier. If there is any remaining fluid, that has to be drained after 2 hours, and chest tube has to be removed if there is a full lung expansion is present on the chest X-ray. The complication associated chest tube thoracostomy, basically re-expansion pulmonary edema, pneumothorax, subcutaneous emphysema, intercostal neurovascular injury, the complication associated to the tube. Coming to the third modality, chest tube drainage followed by the chemical pleurodesis. The common sclerosing agent used for the pleurodesis is mineral, that is talc, which has the success rate around 80 to 90%, and antineoplastic agent bleomycin with success rate around 58 to 85%. Antibiotic, antiseptic, bacterial product, and the cytokine can be used as a sclerosing agent in the management of the chemical pleurodesis. We have the study regarding the success rate of the sclerosing agent in the form of the Benjamin et al. The prospective study of 30 patients has compared the success rate of povidone along with the tetracycline group. The success rate of the povidone is 93.4%, whereas the tetracycline is 93.3%. We have the review of the 38 cases. In case of the tetracycline pleurodesis, the complete success seen in 61%, the partial is 16%, and the failed in 23%. Another matter, the chemical pleurodesis using the talc can be done using the talc cartridge or talc slurry. The process to perform the talc slurry is basically simple. There must be prerequisite of a complete chest expansion on the lung parenchyma. It has to be done. Before doing the procedure, one should insert the lignocaine into the pleural cavity, followed by the 4 to 5 grams of the graded talc in 500 ml of 0.9% saline. After that, the patient, the clamp, ICD should be clamped for 1 to 2 hours, and the patient rotation is not necessary according to the recent study. The removal of the chest tube should be done within the 24 to 48 hours. The second modality of pleurodesis large cartridge. It has a very useful in malignant pleural effusion of unknown primary. It provides a better drainage of the pleural fluid due to the dissection of the adhesion, and it has a better success rate than Tal's-Surrey pleural disease. Where do you have any comparative study between the thoracoscopic style cartridge or chest tube Tal's-Surrey? There's a study by the Dresser et al. Which suggests you have no difference in efficacy between the chest tube and the thoracoscopic pleural disease with the TAL. Although the malignant pleural effusion due to the primary lung or breast cancer improves the outcome with the thoracoscopy. The thoracoscopy provides better outcome with the lower pH value by to 55%. The both even if the high success of the thoracoscopic TAL cartridge, the chest tube pleural disease associated with the low morbidity, low cost has to be preferred over the thoracoscopic TAL in case of the patient with the symptomatic malignant pleural effusion. Comparison between the thoracoscopic TAL cartridge versus the povidone iodine pleural disease. The TAL cartridge is associated with several pleuritic chest pain, fever, longer hospital stays compared to the iodine pleural disease. But the both group achieve good symptom control and equal recurrence. Although the study was very small, it is concluded that the povidone iodine is easily available, cost effective and safe. What are the criteria for the successful of failure of the pleural disease? The complete successful pleural disease is termed as when the long-term relief of the symptoms with no radiological recurrence, whereas a partial successful pleural disease is basically a diminution of the symptoms and partial reaccumulation of the fluid should be less than 50% of initial radiological evidence. And even if there is a partial reaccumulation, it should not be needed any further line of therapeutic thoracocentesis for the rest of the patient's life. And the failed pleural disease basically loss of success as described above. Coming to the
Last 2 minutes, sorry to interrupt, last 2 minutes, try to summarize.
Is of the failure of pleural disease, trap lung, lobulated, these are the causes. In case of the trap lung, we preferably use the long indwelling catheter, pleuroperitoneal shunt, decortication, lobulated MPV with intrapleural fibrinolytic agent. Indwelling pleural catheter basically indicated in recurrent and symptomatic malignant pleural effusion, MP with trap lung. It has the advantage of very short hospital stay, limitation associated with it. Whereas the other treatment modality, pleuroperitoneal shunt, basically done in only in kinase effusion patient, whereas the partial parietal pleurectomy is only associated with substantial mortality and morbidity, not routinely recommended in the era of pleural disease with indwelling catheter. The prognostic criteria associated with the malignant pleural effusion is Lens score. Risk stratification, as you can see, that low risk, moderate risk. These are the guidelines of pleural disease, unilateral pleural effusion diagnostic pathway, the malignant pleural effusion pathway. And these are the recommended clinical practice guideline recommendation by the ATS, which suggests of use of USG in case of the pleural intervention, no treatment for asymptomatic patients. Symptomatic patients should be treated with large volume thoracocentesis, and there is a first line definitive treatment use of chemical pleural disease or IPC in case of patient symptomatic MP with expandable lung, and there is no difference in the efficacy between the TAL cartridge and Tal's-Surrey. Whereas the patient with symptomatic MP, non-expanding lung, failed pleural disease, lobulated effusion, the IPC should be preferred. And the infection-associated IPC should be firstly causative treatment without removing IPC is recommended. If there is no improvement, the removal of IPC is recommended. These are the flowchart for the clinical practice guideline for the MPE. Coming to the summary, malignant pleural effusion is hallmark of concluding end of the all malignancy. The principle of management should be the identification and treatment of primary tumor and also the evacuation of the pleural fluid and prevention of the recurrence. Thank you.
Yeah, thank you very much, Dr. Abhijit, for the wonderful presentation. You've actually summed up very well. And to highlight on some of his points, the most important thing is to identify pleural effusion and the primary, because the management of pleural effusion will completely depend on the primary. Okay.
Yes.
So if you have a highly chemosensitive tumor, like an ovarian malignancy, you're not going to put ICDs in this group of patients. With just 1 or 2 doses of chemotherapy, it would completely make a huge difference. And even in lung cancers, if patients are asymptomatic, now with the advent of the targeted therapy or the immunotherapy, the response rates are too good so that patients improve dramatically and you can aspirate and wait and hold. Putting an ICD is no longer the standard. The moment you see an X-ray with pleural effusion, you go ahead and put an ICD is not the rule anymore. Okay, so thank you very much once again. So before I take the questions, I would like to take this opportunity to thank all the three speakers for doing a wonderful job and phenomenal job, I would say, and for covering all the points. So just request that I request you all to upload your presentations onto the DNB WhatsApp group so that everybody will get benefited by the presentations, okay, for the academic interest. Now, I will just take a few questions which are there. So you have any salvage lobectomy or pneumonectomy as higher morbidity. If we are considering, should we do it at the time, before RT? Yes. So these are patients like I've already answered, but I would like to reiterate that, if the lesion is inoperable, there's no question of upfront surgery first anyway. So the choice here, the discussion comes here, whether should we try neoadjuvant chemotherapy or chemoimmunotherapy and then followed by surgery, or give definitive CTRT followed by RT. So here the most important is, what is the reason for unresectability is a most important question for you to decide whether you want to give CTRT or you want to give some form of neoadjuvant therapy. So if you think that the patient may end up in some sleeve resection or a lobectomy without morbidity at a later date, then probably you could try neoadjuvant. There is no level 1 evidence to make this statement from my side, but this is purely based on from all the trials, whatever is safe to show that surgery is non-inferior, and wherever you can do a lobectomy, probably you could try and neoadjuvant. With immunotherapy coming up, with personal experience too, the response rates have been phenomenal with immunotherapy. So probably you could try this as an option. But if it is inoperable because of, you're not going to get a lobectomy, or, at some point of time, or it is infiltrating major structures, you can never get an R0 resection, bulky mediastinal nodes, multi-station bulky, then concurrent chemoradiotherapy still remains the treatment of choice. Like, for example, I think Dr. George covered in his previous talk on management of Pancoast tumors. Like, these are tumors where neoadjuvant chemoradiotherapy is the standard of care. Yes. Is there more morbidity? Definitely yes. But the morbidity of CTRT followed by surgery, that is definitive CTRT followed by surgery, has more morbidity when compared to the neoadjuvant doses which are given at the rate of 40 to 45 gray followed by surgery. And you should take all precautions to ensure. The most common morbidity that you commonly face in these group of patients is the bronchial stump blowout. So you should take all precautions to ensure that the bronchial stump is managed well. Okay, so this is about CTRT or salvage lobectomy or pneumonectomy. So what will be the preferred option? Yes, that we have answered. What is the current status of mediastinal staging? So the choice of mediastinal staging, all patients, I think this has been covered very well by Dr. Sabita in the previous lectures. Any patient which is peripheral and less than 3 centimeters and no uptake on PET does no need for further mediastinal staging, until you have a adenocarcinoma or a low grade uptake on PET. Even in those patients, then you may have to consider, because your PET may not be a foolproof evidence. Rest all cases, you should do some form of mediastinal staging. So what is that mediastinal staging? So EBUS remains the first choice of treatment. And there was always a debate, EBUS positive, take it as positive and go ahead and treat as N2 disease. But EBUS negative, we always had, the classical teaching was to do a mediastinoscopy. But with the recent MEDIAS trial which is published, so all patients who underwent an EBUS and were negative were randomized to undergo mediastinoscopy followed by surgery versus upfront surgery. So this actually, the MEDIAS trial actually said that there is no difference and mediastinoscopy can be omitted, because there were about 8% of patients who were incidentally diagnosed with N2 disease, those who underwent surgery without undergoing, but their outcomes did not change. So probably you may avoid mediastinoscopy with the advent of with the forthcoming of MEDIAS. But mediastinal staging is mandatory. I would like to stress this, because you shouldn't say that, no, just because we're not doing mediastinoscopy, we would take away mediastinal staging altogether. No, the trial is mediastinal staging is mandatory. Okay, so yeah, pancos we have already covered, and what you prefer for pleurodesis in a malignant one, talc or bleomycin. Our choice of pleurodesis is talc, but unfortunately, due to non-availability, non-affordability, then bleomycin is the other choice that we commonly use. There are no specific indications. As a trainee, I have been using talc always and no other agent, and we have had very good results with talc. But yes, availability is one thing, and the expenses, affordability. So, which you may have to choose other options like bleomycin is the second option. Okay, I think there are no further questions, and yes, yeah, there are no further questions. So, and I think it would be. I would like to thank once again the students who have actually taken efforts and made wonderful presentations. I was extremely impressed by the presentations, and I think we will have this more in future. And I would like to thank Dr. Somashekar to actually having coordinated this. He could not join the talk today, but he has been constantly messaging and inquiring about how it's going on. And Mr. Navneet, thank you, and over to you.
Thank you very much, trainees and faculty members, for joining the session.
Thank you.
Thank you, sir.
For the opportunity.
Thank you, sir.